Yeah, good evening. Hello, everyone. Thank you for joining us this evening. Uh, Today, being the first day of the Endocrine Week, which is to which has replaced the actual endocrinology conference, a national endocrinology conference. And today, in this evening, today we are going to discuss on SGLT2 inhibitors as a class, and more particularly remogliflozin, which is a recent molecule which has been introduced and it's becoming very popular. Today we have a panel discussion where I have with me the president-elect of Endocrine Society of India, Dr. Rakesh Shahai, and Dr. Sanjay Kalra, the current president in Endocrine Society of India, who will be joining us later in the panel discussion. And today, to start with, Dr. Krishna Prasad from Torrent Pharmaceutical. He's a medical advisor there. He will be presenting, take us through some slides, PowerPoint presentation, where we are going to discuss about SGLT2 class as a whole and the relevance of use in Indian population in the context of cardiovascular and renal, supremacy, which have been shown in different CBOT and renal trial, and based on that we'll carry forward our discussion, and we'll try to find out where we can place remogliflozin in the current armamentarium of anti-diabetic management. With these few words, I request Dr. Krishna Prasad to start his presentation.
Thank you, sir. A warm good afternoon from the environments of Ahmedabad, Gujarat, where I think unfortunately or fortunately there has been a curfew which has been placed. I hope there'll be logins for this session, which is by default, not by design. So with that, I would like to start my deliberation on the current topic of cardiorenal benefits with SGLT2s, where I'll be focusing on remogliflozin, as Sir has rightly said, before we have an freewheeling interactive panel discussion, which speaks about the current insights and clinical experiences which we have on this molecule before we really place it in the right frame or landscape of type 2 diabetes management. So I'll just start with the slides. Can I have the slides or? Yeah, I hope the screen is on.
Yes, sir.
Yeah, I'll straight away go to the next. Yeah, so when we are looking towards the current landscape of type 2 diabetes and its management, and probably understand the relevance of SGLT2s, not only for their obvious glycemic benefits, but also for their extra glycemic effects, which have been also been rightfully understood and placed accordingly in the current guidelines of EDA, if not in ESC, is probably the leading perspective which is being sought out, and that is on the new molecule which we considered as an Indian origin, where the trajectory of the development path of remogliflozin was first unveiled on the international soil, but in 2016 we did find the fact that the last leg of the development of remogliflozin was carried out on Indian soil before we had the introduction of this novel remogliflozin in the Indian context. So what is the clinical perspective, or probably what is the understanding about SGLT2s and for their current flavor in the market as a current preference? I think that's what is going to be unfolded in the next few slides. So, ladies and gentlemen, I think diabetes doesn't require any introduction. It has been galloping and making greater strides in terms of overall burden for greater morbidity and mortality. It has been defined as a complex chronic disease which is characterized by insulin insensitivity, otherwise lack of impaired secretion, which leads to multiple risk factors and probably otherwise complex micro and microvascular complications, which obviously require continuous medical care with multifactorial risk reduction strategies, which obviously go beyond glycemic control. But what about a proposition which can probably otherwise multiply and probably otherwise act as a force multiplier and give you both glycemic as well as extra glycemic effects for us to probably make a do with other risk reduction strategies? So that was what was promised through the SGLT2 introduction, and with the unfolding of the cardiovascular outcome results, which were so radical and which were so forthright, speaking about their clinical impact and benefit in reducing the risk of myocardial infarction, stroke, and cardiovascular death, to mention a least. But also, I think even the latest information that we have for a new class or a new generation of gliflozins, which has been recently been published in Imaging for its impact on uh, uh, hospitalization reduction for heart failure in patients of type 2 diabetes with CKD. I think the writing, if not on the wall, but probably also on the clinical chambers, seems to be the fact that yes, SGLT2s are in reckoning. But I think we have to take this in with a pinch of salt, because when we look at the unfolding of the CVOT trial design and the development, I think it was not by design that they were designed to give you cardiovascular benefit, but I think they were designed to give us some safety clues about their usefulness as a compliance and adherent tool when the patients of type 2 diabetes have to be compliant to. So it is by serendipity that yes, we did get across a cardiovascular benefit, but is this cardiovascular benefit really of clinical impact? I think that is where the ticking clock hypothesis for type 2 diabetes in terms of early induction of macrovascular complications has been well endowed to be associated with type 2 diabetes. And in fact, the DeFronzo's concept note on severe defect of insulin receptor signaling mechanisms leading to MAP kinase and related inflammation and related atherosclerotic changes probably explains about early intervention which is warranted with novel anti-diabetic agents which have both glycemic as well as extra glycemic effects. So in this line, I mean, we don't require any further introduction on the conventional and currently available anti-diabetic agents. And we know the fact that, yes, whether it is metformin or maybe otherwise even the GLP agonist, all of them seems to be having some overt cardiovascular benefits for them to be used either as an initial line therapy or maybe as an add-on therapy. But I think it goes probably further to say and suffice to say the fact that yes, SGLT2s were in fact the first ones to show a positive cardiovascular outcomes. And probably it is this mechanism of action which was defying all the logic to have a cardiovascular benefit. So this slide probably says the fact that yes, SGLT2 is a novel insulin independent approach to remove the excess glucose to have a glycosoric or maybe otherwise glucosoric effect which is probably brought out by the early inhibition of the SGLT2 receptors in the proximal renal tubules, which are responsible for almost about 70 to 80% of the glucose reabsorption, which is being blocked by SGLT2 inhibitors. And over a period of time, as we continue to give SGLT2 inhibitors, which are probably of two kinds, one is highly selective and another one is a balanced kind, we do find the fact that there is an upregulation of the SGLT1 receptors in the distal tubules to say the fact that yes, a molecule with SGLT1 receptor inhibition probably also is going to be having a consistent, durable, and probably otherwise having a persistent glycemic control effect. So overall, whether we speak about a highly selective or probably those a balanced or dual SGLT2 inhibitor, I think it goes without saying the fact that across the molecules under this class of SGLT2 inhibitors, we do find the fact that most of the times there is a glycemic control or maybe otherwise a glucose loss of almost about 70 to 80 grams per day, which is probably otherwise equivocal with all the SGLT2 inhibitors. And that could translate into HbA1c reduction of 0.5 to 1.4%, with additional safety profiles to understand the fact that yes, it has a less propensity or less action on the natural course of type 2 diabetes landscape, and that is on beta cell function, and where it is likely to have an protective effect leading to low risk of hypoglycemia. So when we look at this glycemic control, which is so obvious and which is translating into greater glycemic control, is the extra glycemic effects of body weight reduction as well as blood pressure reduction, which is probably catching the attention and throwing into limelight the current SGLT2s in the market. So what are the potential mechanisms of cardiorenal benefits of SGLT2 inhibitors? And probably can we call them as a class effect with all? So that's where I think this slide has been often used in most of our interactions as well as the continuous medication programs which are there to say the fact that yes, gone are the days when the early perception was glycosuria and natriuresis mediated side effects such as urinary tract infections, which are the hallmark sign of HGLT2 inhibition. But we do understand the fact that it is this very glycosuria which translates into an HbA1c reduction or a glycemic control, which is less likely to cause endothelial dysfunction and therefore atherosclerotic damage to the myocardial vessels. So while we speak about obvious glycemic control and its translational impact on the macrovascular complications, is the fact that the extra glycemic effects have been further highlighted and potentiated by this graphic, which shows the fact that on the extreme left-hand side, that as there is glucosuria, there is a caloric loss, which could probably explain the weight loss, which is there with this class of compounds, if not to reduce the lipids, other fat levels. So they are lipid neutral with having little impact on the waist circumference. But obviously, because of this lipid neutral effects, they are likely to be so commonly used in obese, otherwise the lean variety of Asian phenotype of type 2 diabetes. So while we look upon this neutral effects of SGLT2 inhibitors for it to be used in the Asian phenotype, in fact, I'm happy to share one of its kind of an interim analysis of 37,000 cases of remogliflozin, where we did find the fact that yes, remogliflozin was being proposed to be used as an add-on therapy, despite the use of other risk factor mitigation strategies of dyslipidemia and hypertension. And most of the cases, that is almost about 99 out of the 100 cases, was the case identified to be having an increased waist circumference, if not for abdominal obesity. So while we are speaking about this lipid neutral effects of SGLT2 inhibitors, for them to be taken to the next level, I think what steals the thunder is the extra glycemic effects, what we call it as cardioprotective and renoprotective effects. And to explain this point, I think it goes without saying the fact that yes, when we are inhibiting the SGLT2, that is sodium glucose transporter mechanisms or the channels, it also seems to be inhibiting the sodium potassium ATPase channels, which are there in the renal tubules for it to cause a fall in the blood volume. And probably it is this fall in the blood volume, which is probably likely to be causing a decreased volume related or decreased preload related myocardial stretch for it to cause an improvement in the myocardial contractility. So while the blood volume reduction and otherwise plasma loss is probably correlating with the decrease in blood pressure, I think the ancillary effect also seems to be a complementary effect on the renal vasculature. Because when we have a decrease in the plasma vasculature, there is a likelihood of reduced blood supply. So the reduced blood supply, in fact, has been circumvented by this important compensatory mechanism, what we call it as tubulo-glomerular feedback. So because of this tubulo-glomerular feedback, the RAS system gets activated, and this RAS system is supposed to, in the physiological range, not in the pathological range, is supposed to maintain the vasculature and the tone of the afferent renal arteriole for it to have an renoprotective effect, which has been so commonly found with some of the latest gliflozins to be marketed and to be already having a pivotal studies to be there under their armamentarium. But while we look at the possible correlates of this renoprotective effect, which is probably translated from increased glomerular hyperfiltration to be reduced as intraglomerular pressure, which has been considered to be renoprotective, what defies logic is the persistent chronic benefit of SGLT2 inhibitors with type 2 diabetes heart failure cases, where most of the cases of type 2 diabetes are going to be landing up with vascular dysfunction. So what explains the benefit of SGLT2 inhibitors in such cases of type 2 diabetes with probably otherwise underlying risk factors or pathological defects of heart failure has been not completely and clearly explained by the earlier mechanisms of glycosuria and natriuresis. So the growing hypothesis seems to be underlying the fact that yes, the diastolic dysfunction which happens in type 2 diabetes is resulted or it is resulting in decreased stiffness or increased stiffness and decreased contractility. And if the heart musculature doesn't have adequate oxygen content for the phosphorylation of the actin myosin filaments through the calcium entry, then it is likely to go into a state of failure where it can't be compensated in case of decompensated heart failure. So the growing concept seems to be the fact that yes, at the tissue level, if not at the vasculature, there seems to be an hypoxia, and this hypoxia seems to be better controlled by the improvement in the mitochondrial bioenergetics and the improvement in mitochondrial, uh, uh, biogenics, which has been so importantly and so wonderfully highlighted by none other than Sudha Mudliar in his recent papers. So, can the use of SGLT2s cause a shift in fuel energetics, explaining the beneficial cardiovascular effects? Is the mood question, wherein the mood question about alternate fuel or the thrifty fuel in the form of ketones has been suggested to be coming into the rescue of an failing heart, which is so commonly found in case of type 2 diabetes. So while we can explore and understand the fact that yes, we do require the failing heart to be re-energized with energy, and the energy otherwise phosphorylation bundles, that is ATP. This ATP can be generated with various substrate utilization models that we have in the form of glucose, fats, and otherwise by ketones. But mind you, what are we discussing? We are discussing a case of not a healthy case, but a case of type 2 diabetes where both glucose and fatty acids are not available for the energy production. So when we look at the energy production to be alternatively looked upon, then probably comes in ketones, and the ketone burning, which yields the energy with an unit consumption of oxygen, seems to be much less as compared to fatty acid burning. So that's where the concept node came in very strongly to say the fact that yes, if the failing heart or if the type 2 diabetes heart doesn't have glucose and fats, can an efficient energy unit can be obtained from the burning of ketones and ketone bodies. So that's why this graphic and the number will show you the numbers as the ATP yield per oxygen unit consumption as being equivocal as that of glucose, which is considered to be the gold standard. So when we speak about this re-energization of the myocardium and the mitochondrial bioenergetics to be coming into picture, what is the relevance? Yes, the relevance seems to be an optimal or maybe suboptimal basic substrate utilization as decreased glucose oxidation, which leads to a decreased PO ratio and decreased cardiac efficiency, which probably calls in for the failing heart to be there in case of type 2 diabetes with uncontrolled heart failure. So what happens with SGLT2 inhibitors? I think the alternate or the thrifty fuel hypothesis, which has been so wonderfully highlighted, probably suggests the fact that with increased availability of fatty acids because of the loss of glucose, what we find is the fact that fatty acids are being delivered to the mitochondria, but the mitochondria is not able to utilize these fatty acids. And that's why it starts looking at alternative, and that is ketones. So once ketones are being generated, what we call it as ketogenesis, and they are being burned, what is happening is the fact that yes, through the direct mechanisms of energy production, as I alluded in the preceding slide, are we finding the re-energization of the increased PO ratios for this type 2 diabetic heart, which is now been re-energized with an SGLT2 inhibitor. So this is touted to improve the cardiac efficiency and the contractility, and that is probably going to be causing the arrest, if not the prevention of the progression of heart failure, which is so vital in such cases. So obviously there have been successive studies, even with as latest as last week with the NEJM publication, to say the fact that yes, there is a decreased rate of hospitalization with type 2 diabetes cases with heart failure. But is this a class effect because of improved mitochondrial bioenergetics and improved mitochondrial biogenesis is the mood question being asked. So what is bioenergetics and the re-energization of the myocardium with ketones has been alluded in the preceding slide. But what is also explaining the ancillary effect of SGLT2s is the improved survival of the mitochondria, which we call it as the energizer of our cells, is the fact that there is more number of mitochondrial copies and numbers which are likely to cause more generation of these energy units. And these energy units are being controlled by the activation of AMP kinase. So on one side, we speak about improved bioenergetics, and on the other side, we speak about increased biogenesis, because with increased AMP kinase, what you're going to be having is a cellular coin or a protein which improves the survival time of the mitochondria, and that is SERT. So both of these concepts have been related with SGLT2 inhibition, and that's where our current understanding seems to be the fact that yes, with alternative fuels to be looked upon, is the improved bioenergetics and improved mitochondrial biogenesis through SERT activation is the answer for such failing cases. So that's where we speak about the ancillary benefits of SGLT2 inhibitors, and it's probably the obvious question which comes in such a case is the fact that where do we look at the role of remogliflozin? So just to revisit your memory cells, remogliflozin, as I said, it was developed on Indian soil, where we looked at the recent introduction of remogliflozin as a novel SGLT2 inhibitor, which in fact is having an active metabolite. Yes, it is developed as a salt, which is remogliflozin etabonate, which is a prodrug of remogliflozin, which gets further broken down into active metabolites. But more importantly, is its lack of metabolism or lack of assimilation or digestion for it to be having any adverse drug-drug interactions. But I think what really comes across from this pharmacodynamic and pharmacokinetic chart or a slide is the selectivity right at the bottom of this row of this chart. That when we look at remogliflozin and its current perspective with other gliflozins, we do understand the fact that remogliflozin is probably a dual SGLT2 inhibitor because of its balanced or relatively balanced inhibition of SGLT2 as well as SGLT1. Now, SGLT1, as I said, is not only there in the renal tubules, but it is also seems to be there in the heart. And that's why probably whether it is going to be having any translational clinical impact or benefits is a point of conjecture. But at this point of time, yes, the daily dose of remogliflozin remains as 200, which is broken down into two dosages. And since it has an impact also on the SGLT1 receptors in the intestine, can the dual, otherwise twice daily administration of remogliflozin with the meals, can it be having an impact on the postprandial hypoglycemia is also an additional element of debate, if not discussion. So while we are speaking about the pharmacokinetic differentiation of remogliflozin and its impact on the SGLT1 receptors, is the fact that yes, does it have an impactful half-life for it to be giving a time in range and maybe it's a full complementary hypoglycemic anti-hypoglycemic effect at the end of 24 hours. So to answer some of these questions about identification of the right dose of remogliflozin and also its relevance in terms of its potency when we speak about the PK-PD differentiation, I think the apt molecule for comparison was dapagliflozin, and that's why the Indian innovator looked at conducting an important landmark pivotal study, which we call it as the phase 3 study for remogliflozin to be assessed in comparison with dapagliflozin. So this was a 24-week randomized double-blind, double-dummy, parallel group, multicentric, active controlled study to evaluate the efficacy and safety of remogliflozin in subjects with type 2 diabetes, where remo was compared with dapagliflozin in the dosage of 100 to 250 milligram, and the primary endpoints being the change in HbA1c from baseline. So otherwise, there was a stable metformin dose, which was initiated in most of these cases, and the inclusion criteria of HbA1c inclusion was greater than 7 and less than 10%. So when we look at the results, which are so dynamic, especially for the cases with a BMI of less than 45, we do understand the fact that the HbA1c was quite up to the expectations of an ideal anti-diabetic agent with a reduction of 0.5 for 12 weeks as compared to 0.7 at 24 weeks, which was again quite comparable and in fact showing a trending towards a better improvement as compared to dapagliflozin with a point difference of 0.1, which was statistically non-significant. But otherwise, as I said, I mean, when we are looking towards the time in range HbA1c control, if not for the target HbA1c levels to be achieved by most of the cases, I think in the remogliflozin, almost 46% of the cases did hit the target HbA1c levels, which is 46%. And when we look at the fasting and the postprandial levels, again, there has been a robust 39 gram per deciliter reduction in the remogliflozin arm compared to 32.4 gram per deciliter reduction in the dapagliflozin arm for comparison of remogliflozin 100 versus dapagliflozin 10 milligrams. So when we look at the SGLT2s, obviously the benefits have to go beyond glycemia for its point of comparison. And that's where the ancillary benefits which were culled out from this landmark phase 3 study were summarized in the slide, which has shown the fact that yes, there is a body weight reduction thanks to the caloric loss of 3 kgs. But obviously it doesn't have an impact on the lipid oxidation. And that's where probably we would attribute to the lipid neutrality and probably otherwise lack of further progression of the waist circumference in patients who've been put on remogliflozin. But otherwise, likewise, any other SGLT2, there is 2 to 3 millimeter reduction in the systolic blood pressure, whereas there has been a bit of a reduction in the triglycerides, which probably holds relevance in the Indian context. But more importantly, a point which was as well also considered for CVT trials was the safety profile, is the point of conjecture and also probably understanding and discussion is the fact that remogliflozin, being a balanced SGLT2 inhibitor, where the glucagon stimulus for the side effects to be coming across with SGLT2 inhibitors in the form of euglycemic diabetic ketoacidosis is so hypothesized to be there in place. Can that be probably hypothesized also with remogliflozin to be not to be there, if to be there? So the safety profile which was found in this study was quite similar, and it was no cases of severe diabetic ketoacidosis which was found in this study. So when we look at the key findings, I think the findings are speaking about the glycemic and extra glycemic effects. And I think that would be suffice for us to quickly have a glance on the slide to understand that, yes, the phase 3 study does prove a point about the efficacy and safety of remogliflozin compared to dapagliflozin 10 milligrams. But when we look at the recent evidences which have been coming up as real world evidences and probably otherwise further collation of the thoughts on the remogliflozin's use and its place in therapy, I thought of sharing a couple of these somewhat recent updates that we have had from American Diabetic Association as an ED updates, where there are a couple of studies where remogliflozin was touted and explored for its extra glycemic effects. So the first study was a comparison of remogliflozin and canagliflozin as an add-on therapy in uncontrolled type 2 diabetes. And this was authored by Dr. Shankar from Patna. And this has probably the details which has been flashed and shown on the slide. 120 cases of uncontrolled type 2 diabetes, which were classified as having moderate to severe hyperglycemia, that is HbA1c greater than 8, who were on a stable dosage of metformin plus a DPP4 inhibitor, were then selected for this real world observational trial, where the primary endpoint was the change from baseline in HbA1c at 12 weeks. So when we look at the results, which is not just looking at the primary, but also at the secondary endpoints, we do find the fact that the HbA1c reduction with remogliflozin was as comparable to that of canagliflozin, while being distinctively superior as compared to the baseline. So when we look at the benefits, the obvious comparisons are there for the effectiveness in the subpopulation of CKD, but more importantly is also the safety comparison for the cases of ischemia, it was limb amputations to be there, which was not found in such a case. So this was a 12-week study, just a point of share of information. And these were the glycemic endpoints which were found to be there in place for remogliflozin as compared to canagliflozin, which was again comparable. And when we look at the HbA1c reduction, again, the number of cases who hit the ideal HbA1c targets within 12 weeks was quite substantial, with 51% of the cases hitting the right levels. And when we look at the weight reduction, it was to an extent of 1.4 kg with remogliflozin 100 milligrams given twice a day. So the overall incidence of SGLT2 inhibitors was obtained and found with remogliflozin as well, where the incidence of hypoglycemia was found to be in fact higher with patients with canagliflozin as compared to remogliflozin. But otherwise, a good food for thought about its fitting into the bill as an one more SGLT2 with having both glycemic and extra glycemic effects. But I think what is really catching the attention is the incidence of type 2 diabetes and concomitant chronic kidney disease, where even the latest updates and guidelines, including EASD and ADA, speak about the role and the place of SGLT2 inhibitors in the special population. Comes to the point of conjecture that does these remogliflozins and SGLT2s are selectively used only for established cases, or maybe also for non-established cases of atherosclerotic cardiovascular disease and CKD. So this was one of its kind of a study that is by Dr. Vishal Gupta, a 24-week double-blind randomized placebo-controlled parallel group study. When I say placebo, the patients were not put on additional arm, but they were on the current standard of care, and that is metformin and metformin 1000 milligram given as single dose. And the primary endpoints in these cases of type 2 diabetes with underlying nephropathy being assessed was being assessed for the change in HbA1c. So when we look at the primary and the secondary endpoints for the change in HbA1c, as well as the secondary endpoints of renal protection, and that is urine albumin creatinine ratio, that is UACR. If not for the HbA1c, there seems to be a robust reduction in the UACR ratio, which was in favor of remogliflozin as compared to the current standard of care, which we all understand is probably going to be not up to the expectations when we're looking at a patient of CKD with impaired EGFR. But otherwise, in patients with stable EGFR, still remogliflozin seems to be giving up a greater renoprotective effect as compared to metformin or metformin-based standard of care therapy. So I think these are a couple of more studies which speak about the real world usage in a broad category of cases, what we also call it as a garden variety, and probably otherwise patients with risk factors, but without established cardiovascular disease, or maybe without established chronic kidney disease. I think we would really look towards some clinical pearls and discussions happening upon the rightful place of remogliflozin in our clinical practice. So with that, I would like to probably open this discussion further on the rightful place of remogliflozin in the panel discussion.
Yeah, that was a nice, exhaustive and yet comprehensive, detailed, update on remogliflozin. I learned a lot. Uh, I got myself updated about the recent trials from India. I think I should congratulate. We should congratulate our colleagues from India who have done a lot of work on this molecule. It's a new molecule. And I would like to two things you highlighted, and I appreciate that very much. Is that you know this SGLT1 aspect, which is a new thing, which is not discussed in relation to the classical SGLT2 inhibitors of the predecessors of remogliflozin. So that's a that opens a new vista. I mean, new approach to treating diabetes, a new understanding in this science of SGLT inhibitors. So, Dr. Rakesh, yeah, your opinion.
Yeah, I think That was a very good presentation, and we, as you said, we did get a lot of information, new information on that, particularly the studies done from India. And the two important things which I probably wanted to highlight, one was that the SGLT1 and SGLT2 selectivity of this molecule, how it differs from the other molecules, and as you said, the additional evidence, I mean the presence of some amount of effect on the SGLT1 adds to the glycemic benefit. Whether it does have other benefits is something which has to be further studied. Whether that translates into benefits in other the extra glycemic benefits is something which I think all of us are looking up to. And one of the important trials, the SCORE trial, is probably going to give us some information on that. We are awaiting the results of the SCORE trial. We're part of that, and the trial has been completed, and we are waiting for the results to be announced. And I think that's going to be an interesting sort of information that will come out from the SCORE trial, and that will tell us, because that's one of the other molecules, the sotagliflozin, and one of the other molecules which has a significant effect on the SGLT1 receptor also.
Yeah, actually, basically, SGLT1 is a low capacity but high specificity receptor. I
Yeah.
mean, it has to deal with a very small quantity of glucose molecules, which is coming to the distal part of the tubule. Physiologically, it's not that important, but then the up-regulation is a totally different issue. And at the beginning of this science, we didn't understand about up-regulation because we are more focused on the SGLT2 per se. But then we found that some of the people they respond quite well. Some patients you see that they respond quite dramatically. You're so happy, in weeks' time, their, HbA1c is approaching normal 12 weeks or so. The next year, patient comes back to you, you find that patient has started gaining weight and his blood sugar has deteriorated. So that is, I mean, that actually, if you compare to DP4 inhibitors, I would personally say that DP4 inhibitors are a little bit, kind of a lesser molecule in terms of reducing HbA1c. But then, if you get an effect with a particular DP4 inhibitor, this is sustained. It may be, a bit smaller, maybe it may not be as good as SGLT2 inhibitors, but then it is sustained. But in some SGLT2 patients responding to SGLT2 inhibitors, later on you find that they are not responding at all. The dramatic response is gone. It could be explained by gradual upregulation of the SGLT1, and the few SGLT1 which is present in a normal human being, maybe they may be multiplied, and that may be another mechanism by which the glucose gets a re-entry to the system, and again the patient can become hyperglycemic. And that's a very good point. I think this needs further evaluation and further understanding. Uh,
If
Dr. Rakesh,
building on that,
I want to ask you a question from your clinical experience. And if you assume that there is a substantial SGLT1 inhibition by this molecule, or maybe canagliflozin, should we not see some diarrhea or some GI side effect, more patients with GI side effect if you use these two molecules? Have you actually seen more GI side effects with remogliflozin or canagliflozin compared to the other two?
well, I would not say that I've seen
Yeah.
in effects. I mean, side effects of diarrhea more often with any of these specific molecules. But I have occasionally encountered people having diarrhea once they started a SGLT2 inhibitor, but not specifically. I can't. I mean, because we have been very far and few, that I can't specifically say that it's with one molecule that I've seen rather than with another molecule. That's what my experience has been, clinical experience. Then the other thing which I wanted to just add on was that if you believe that, I mean, if this SGLT1 inhibition is going to have a significant important role, then I think that is going to bring about, apart from a slightly greater reduction in HbA1c, it is likely to have a more durability also. Add to the durability. That is one more thing that we need to look up to.
Longer studies, yes.
Yes.
We need longer studies.
Yeah, little longer data will tell us. Follow-up of these real-world studies, which were 6-month duration studies. I think we should extend these studies and see whether these benefits are persisting beyond a year or so. That would be interesting.
Yeah. Another question I want to ask to Rakesh and Dr. Krishna also. If you look at the energy substrate hypothesis for both myocytes and nephrons, uh, where even Dr. Modeller's article also talks about some nephrons utilizing ketones as a substrate, if I'm not wrong. I mean, the same mechanism might help in some nephrons, I guess, that more efficient energy utilization or renal uh, parenchymal cells or something. Anyway,
Yeah, I mean, they speak about not probably the fuel substrate, but probably they speak about the sodium hydrogen exchanger mechanisms, which is probably there in the heart, and probably the sodium potassium ATPase channels in the kidney, the tubules.
so I mean,
So,
do you need a critical number of normally functioning non-fibrous myocytes and nephrons for these drugs to act, the class of drug as a whole, or you can expect to have benefit even at a late stage also?
I
yeah,
think
I think that's where the heart failure reduction, I mean, reduced ejection fraction studies have been so dynamic and so pivotal for SGLT2s right now. And we are really waiting with bated breath on the results of SGLT2 inhibitors for heart failure with preserved ejection fraction. I mean, those patients with diastolic
Why,
overblaze.
Rakesh? What is your opinion? I mean, my hunch is that even late stage also there will be still some benefit. So, what is your opinion?
Yeah, I think as you rightly pointed out that whether the critical mass of myocytes and nephrons is required to provide that benefit, that's a very interesting question. And because right now, I think if you look at the studies that have been undertaken, the inclusion criteria has been like GFR over 30 or around 30. That's the usual, that's, and some, I mean, the least I think was 25, below which they have not been studies which have not enrolled people, I mean people below GFR the 25.
25 to
So
60. Yeah.
yeah, even the current, I think there's this um, the sports study which looked at sitagliflozin also looked at GFR of 30 as a kind of lower cutoff. The Cana study also looked at that. Even DAPA CKD also looked at that. So I think we don't have information on what exactly happens when the GFR is even lower. But although we did see that when GFR goes below this, those who are enrolled with 30 and their GFR goes down, initially goes down, but then they have preservation of the GFR, and it works even at lower GFRs. But when we start off with a very low GFR, whether it helps at that point of time, whether it does improve the GFR is something which is still unanswered, and we don't know about that very clearly.
Yeah, actually, you know, you know, it's not my hypothesis, but my opinion is like when you talk about a particular I mean EGFR or particular treatment level, it's not that the entire population of nephrons are dead. Some are actually functioning as, in fact, they are hyper functioning, and it's that hyper functioning stage where afferent arterioles are dilated. At that stage, these molecules are going to help a lot because that will prevent the future death of those hyper functioning nephrons, and that way at least it can preserve those nephrons for long term. And that's why it is still rational to use it even at a low GFR. I cannot give you a cutoff, but then rationally that even at 30 eGFR, you have a substantial number of cells are still alive. They're not dead. They're not fibrous. They are functioning. That's why you are maintaining some kind of a balance between hyperuricemic toxins and urine output. So I think till that stage also, even if you're below 30 also, you can still have benefits formed for the nephrons, and at least some hyperfunctioning nephrons can be put to rest by constricting the afferent arterial system through that natriuretic mechanism, tubuloglomerular feedback, which you have mentioned. So the benefit should be there. Although the glycemic benefit for that, I guess you need a critical numbers of nephrons for glycemic benefit, but not for the not for the, with regard to the saving your future nephrons. I mean nephrons for future. With that regard, probably the critical mass of nephrons are not that important. It is as important in excreting more glucose and bringing down the hyperglycemia. So that's why sometimes the clinicians get confused about these two parts, I guess. And in future, we will know more about it. And indication-wise, probably the EGFR cutoff is going to change for this molecule.
One interesting point that I found very interesting was with, from the presentation of Dr. Krishna Prasad was, he was highlighting the fact that the SGLT2 inhibitors acted the afferent arteriole, and the RAS system works in the afferent arteriole, and sorry, the efferent arteriole, and he was showing us the data that they could be a reactive sort of rather activation of the RAS system once you're blocking the SGLT2 pathway. So I think in that context, I just wanted to highlight that most of the studies where we looked at, where we looked at the renoprotection, whether you the Credence study and all that, there was a necessary inclusion criteria was to have people who were on RAS blockade. So those who were on adequate RAS blockade only were used, were included in the trial. So therefore, I mean, you had a, I mean, when you're using additional RAS blockade, then I think you have the best benefit of using a SGLT2 inhibitor. Using it alone can have the, can be counterproductive in terms of increasing the RAS activity, and can sort of initiate a little bit of increase in the intraglomerular pressure. But
Yeah, I
using
think
the RAS blockade will complement with the SGLT2 inhibitors and have provide that additional benefit. What's your thought? What are your thoughts on that?
I think that's a wonderful thought as a clinical pearl because it was as latest as just a couple of days back as a review on SGLT2s where they said the fact that yes, the tubuloglomerular feedback mechanism is quite apt for the RAS rise or stimulation, but then the RAS stimulation still seems to be in the suppressed range. So that was the term which really caught my attention and probably said the fact that yes, this seems to be hypothesis, and probably I think you hit the right note, saying the fact that probably it makes sense to have a protective cover of an ARB or RAS inhibitor already there in place, so that probably we are not going to be missing out on the obvious benefits as compared to the risk.
At least this is a good point because Dr. Rakesh should be remembering on target trial, which came out in the beginning of this millennium, and then that time Remipil was a newcomer, and we already had Hope and Micro Hope in the late 90s, and then Dr. Salim Isuf's team they started this trial comparing a new molecule like telmisartan versus Remipil and dual RAS blockade. And as the study began, we started hoping that this is going to be a miracle. I mean, you block both the things, you're like physiologically 100% correct in doing so, and you're going to get extensive benefit. But look at the result. Look at the
Yeah,
results. I
yeah,
mean, there was no benefit. In fact, there were some harm. Some patient had so you cannot exactly extrapolate your basic science hypothesis to clinical outcome, right? Like rosiglitazone was supposed to be such an attractive drug for metabolic syndrome. It never showed its benefit. Anyway, so I guess now, as regards the SGLT2 inhibitors, we are getting good clinical data also about regarding concomitant use with RAS blockade. In fact, if you remember the trials with Onglyza, where we had the more heart failures. In fact, some people used to hypothesize that concomitant use of anti-RAS agent is associated with more heart failures in DP4 inhibitors from some subset analysis or so from the trial with DI's molecule, I mean BMS molecule, and a later on TACOS trial also. But that is not substantiated by good statistical evidence. But that was an hypothesis. But here again, we have got enough data because 80% are using anti-RAS agents, and on the top of that, you are using this molecule, and we also supported by a physiological or physiological hypothesis. So I think I don't think we will have a bad experience or nightmarish experience with this combination at least, unlike on target.
I think it parallels the effect that, I mean, the logic that you use for combining this with the DPP4 inhibitors, SGLT2 inhibitors with the DPP4 inhibitors. We say that the glucagon excess which is happening with the SGLT2 inhibition is going to be tackled with the DPP-4 inhibitor, and that sounds logic, and we have data showing that that benefit is seen. So
Yes.
similarly, I think this is the logic behind the combination with the RAS blockade.
Yeah. I think for metabolic protection, you have the combination of DP4 inhibitor and SGLT2, and for renal or cardiorenal protection, you have the anti-RAS agents and SGLT2. So I think we are living in a good time. These two combinations are very essential for us, metabolic physicians, actually.
Right,
Absolutely.
right.
So,
True.
and Dr. Rakesh, I have another question. I'm perplexed by this question. Like, there is a subset of people who do not respond to SGLT2 inhibitors. Those who respond, they respond dramatically within a couple of weeks. You have the weight reduction, you have the glycemic control, etc., which is supported by HbA1c in the later date, of course. But the response would come very fast. In fact, initially when we used to use it, we were like every day we used to get calls from patients taking insulin, sir, my blood sugar is falling and falling and falling. But there are some patients who would never respond. So, can you, from your experience, can you give a clinical profile of the patient who would be responding or who would not be responding? Is there anything in that clinical that our phase 4 experience or real world experience? Is there any published paper, Dr. Krishna also? Has anybody done any clinical profiling of responders and non-responders? I mean, this is a very critical question from clinician's point of view. That's why I'm asking.
Yeah, because I'm not aware of any study like that. I would ask Dr. Krishna first to answer that. Then we can probably look at our clinical experience and try to dissect out some points.
Yeah, I mean, as an avid clinical researcher and probably as a special interest area where I've looked at personal profiling in developing customized and individualized therapies, I think as a clinical researcher, we are probably biased in having the right patient exposed, if not for all the patients being exposed. And that's where the criteria for inclusion and exclusion seems to be obviously taking the thunder out of the answer, rather the probable answer to this question. That are we looking at it as an elderly for volume depleters or for a consistent therapy? Is it going to be in combination with diuretics? I mean, so I don't think we could find any patient who was labeled as non-responder, at least for the some of the studies that we were exploring screening and also the studies which were conducted. Almost more than 60 to 50 to 60% of cases have hit the right HbA1c targets. In
Yeah,
fact,
but then there
this
are
is the
still some
response.
people who won't be responding. But that can happen in any clinical trial. But in our practice also, you keep on writing this molecule and you find such good results, and you start believing that whenever I'm writing, I'm going to get excellent results. But then suddenly you find a person who is not responding at all. You have to stop. Even you have to go to some other molecules like whatever. So,
I think
in
we
fact,
we
yeah,
need to, we need to look back at our earlier discussion where we said that the falling GFR could be one factor. So if you have probably had a little lower GFR in these individuals, they probably have lesser glycemic response. Because what we're discussing now is the glycemic response, which we are seeing immediately. The extra glycemic benefits and long term benefits are seen. I mean, in the sense whether we have renal preservation or whether we have preservation of whether we have cardio protection, that is seen on a longer term, longer sort of period of follow up. But for the immediate follow up, we are speaking of the glycemic benefit. So I think again it's probably the GFR and also the SGLT1 act. I mean, upregulation, which is probably playing an important role in that.
yeah. I think that's the one area who you can actually think about and
Right. It's important to
study.
actually have look at these people who are not responding, and
Yeah,
and,
I think
and
that could be even I think to your medical team also. I think you can as you plan your phase 4 trial. You have a huge. I heard that you are planning a physical big trial. Is it
Yeah.
going on? Yeah, a phase 4 trial.
Yeah, it is going on, and we just closed down on the interim analysis. But notwithstanding the current
How many you have
study which is
recruited?
underway, but
Sorry.
we would be looking towards
How many
greater.
you have recruited?
So right,
speak into that because although it's unpublished, you could just tell us a little bit.
At least, yeah, give us a status.
for a curiosity, we would like to know.
Recruitment status, like you have recruited how? What is the number you're looking at? Number of subjects participating.
Yeah, I think one was, we were looking towards 1,500 odd cases who have been looking at patients of type 2 diabetes with 2 or more risk factors without established cardiovascular disease coming through. So right now we have got the patient data for out of the 1,500, 352 cases who have fit into this high risk criteria of patients with type 2 diabetes, that is HbA1c more than 7, clinical adiposity, which is BMI greater than 23, waist circumference, which is more than 90. And we are looking towards 2 or more risk factors, that is in the form of diabetes and hypertension.
So you have recruited 300 odd patients till now.
We have recruited 1,500 cases, of which we could get this subgroup of high risk type 2 diabetes, which is probably also a criteria list for assessing the lifetime cardiovascular risk as per GBS3.
So it is going to be prospective trial. So you'll be looking at HbA1c reduction. So I think so as a second.
Yeah, but in this enriched population.
As a secondary endpoint, you could keep the profiling of, profiling of the patients who are responding fast and who are not responding. I think that could throw new light on, this molecule, and it will be very useful for us.
I think when your initial presentation, you were speaking about some 37,000 data.
Yeah, that was the other study, which was a case cohort of remogliflozin prescriptions, almost involving about 45,000 cases, of which we have completed the interim for 37,000.
That's good. That's good. No, I think within that 45,000, you will be having people who are responders, who have good time in range and who are not having good time in range. So why don't you do clinical profiling of those patients? And there could be so many papers which could come out of that, and it could throw new lights on this whole science. And very clinically very useful, I think.
Yeah. I think point well taken. Even from this discussion, also what has come in very strongly is the renal protection effect, and probably otherwise the CKD profile and the EGFR levels. I think that was a point which we didn't make notice of.
Okay. So I think we are approaching 6 p.m. now. I mean, but one last question to Dr. Siva, and Dr. Rakesh can also he can throw some light here. Again, this is hypothetical. In some patients, we find a significant postural symptoms for which we have to stop the drug. And is there anything to do with the RAS activation? Like people who activate RAS, RAS activation, is it basically a protective mechanism not to have postural symptoms with this drug? Is it going to protect somehow? Probably RAS is going to increase the intravascular fluid, constrict the distal vessel to some extent, and that way it is protective. And people who do not, raise their renin-angiotensin hormones, the hormones in that axis, they are prone to more postural symptoms. Yeah, it's a question, of course, an observation and a question. So, what is your opinion, Dr. Krishna, Dr. Rakesh?
Yeah, at least in the studies that we have done so far, we couldn't get any obvious safety signal on postural hypotension. And as rightly said, probably as we are looking towards glycose as well as natriuresis, probably as I broadly see it as an osmotic diuretic. I think, as rightly said, instead of depleting the intravascular volume, probably it is more to do with the sodium-related interstitial fluid and edema loss, which is so associated with SGLT2. And that's where probably, unless the case is volume depleted, or maybe otherwise dehydrated, I think
in normal person, normally drinking water. In some patients they come back with not feeling well, doctor, not feeling well. I feel something. I'm giddy. That symptoms.
Lethargic.
There are not many patients, but then you kind of start remembering those odd patients, because otherwise it's such a successful drug that you start believing that everybody is going to be okay, no complaint, nothing. But this happens. Yeah, Rakesh.
Yeah, as you said, they are far and in between. Very few patients have that. But I think probably one of the factors may be that we are missing out on some factor causing volume depletion. They are little volume depleted. They may be on another diuretic, and those factors could be playing a role. I mean, I think that could be one factor which we may be missing out in these people when we're starting the SGLT2 inhibition, and I think we need to probably look at that. Or they could have a defective, I mean, or they may be on a very good RAS blockade, which is probably what
Very strong. Yeah,
very
not
strong,
allowing that physiological rise in
yeah,
RAS.
not allowing the little physiological
Yeah,
rise.
little physiological. Yeah, yeah.
We
That's a
don't
good
know
point.
that.
That's a good
Uh,
point. We
we
need
don't
to
know
observe.
very
I
small.
think all these things can come up in your huge numbers of patients you have. 35,000. It's huge. I mean, you can't believe it how strong you are. And a lot of these questions can be converted to a exploratory finding. You know, ad hoc
Right.
analysis. Then there can be good exploratory papers, scientific. These are very original thoughts. I think we can put forward to good journal thoughts. I mean, just a suggestion. I think
Sure,
Rakesh, you
sure.
can give your
Thank you.
concluding remarks and we can wind
I
up now.
think we had a very interesting discussion on SGLT2 inhibition in general, and the various facets of SGLT2 inhibition. And I think we really had a very good discussion, and also on remogliflozin and how it is showing a good potential as a very good SGLT2 inhibitor to the coming times. We may get more data, more information on this, and there's a lot of information which is being processed out, and we are looking forward to understanding more about remogliflozin. And as of now, we see that it's a useful molecule. Thank you.
Thank you so much.
Thank
Dr.
you.
Rabin is going to, Mr. Rabin is going to have few words. You can say a few words here.
I think
Sir, it's your program, sir. Thank you very much for making this possible for us. Thanks to Endocrine Society. Thanks to Rakesh sir for giving us that opportunity. I think it was a wonderful presentation. So on behalf of Torrent, thank you all for making this
We
possible.
enjoyed. We enjoyed. We
thank you.
learned a lot. Thank you so much, everyone.
For having us.
And good night.
Bye-bye.
Thank you. Thank you all.
Bye.